scalpel. When you cut aggressively, but not too aggressively. How's that for advice, huh? Where things go bad is when you get really timid with that first incision and you go through the top of the epidermis and then you, I gotta go deeper, and you make another cut and then you make another cut and you've hashed up the anterior neck, all right? Take a look at how fat this person's neck is, decide how deep you think you need to go, and get busy getting down to the trachea. I'll make one vertical incision. If you make it too small, you've got to go back and start making it bigger. Just make it big at the get-go. So I'm talking about maybe 3 centimeters vertically. If you can come around where you can see this, that would be great. Again, I stabilize my dominant hand, my cutting hand, on the patient's sternum. I make one vertical. Hey, look at that, they bleed. Yes, they do, they bleed. As soon as I make that vertical incision, my finger, which picked up and moved off to the side for me to make the incision, my finger goes right back down to into that incision and refines my landmark and refines the cricothyroid membrane. I can take, if I am deep enough, I'm deep enough, okay? If you have to make another incision, then do it, but try not to do this 3, 4, 5 times to get down. If you do airway labs where you're working on pigs, that's a training scar, because people have to dig their way down to the pig's trachea and they're doing multiple incisions and they end up performing poorly on real human beings. So I'm at membrane, turd blade 90 degrees, slide it right over the top of my finger, making sure that I do not run it through my glove and through my fingernail, but I'm making a 90-degree plunge cut through the membrane. These blades are not particularly big, so I may have to advance it to one side to make the hole a little bit bigger to accommodate the tube. People say, well, you don't want to keep this thing midline, so I'll pick it up and I'll turn the blade around, I'll cut in the other direction. You don't have time for this shit. You've already waited too long to make the decision to cut. Let's get busy getting this hole open. You may hear sudden air release as soon as you plunge cut through the membrane. But what I'll do then is fingers going in to hole as blades coming out. My fingers in that hole. Knife, finger, bougie, tube. Knife is done. If I can think about it, I retract the blade and drop it where I can get to it again if I need to, right at the patient's, in this case, patient's left shoulder. Bougie, whether it's a cut down bougie, whether it's a full-size bougie, we'll use full-size gear, goes right over the top of my finger, right where my finger is still into the hole. You maneuver it as best you can. If you have to, you pull finger out of hole to get the, yep. Sometimes that happens. There we go. Bougie goes through hole and now finger can clear hole. I'm still maintaining control of all this, but I can take this bougie and I can, it's coming out under his shirt here because the task trainer isn't very deep. But I can bury this. I can get this deep enough that if I let go, I'm not losing control of this. All right, if I let go completely, this is buried. It's not coming out, as opposed to, it's one of the reasons I don't care for a hook, because if you use a hook, if that's your system, then train with your system. But if you use a trach hook to lift up the cricothyroid ring, or the cricoid ring, if for whatever reason you lose that, you're going back to having to try and find it and pick it up again. I like burying the bougie. You can then either have somebody assist you, or you can take tube and railroad it, Seldinger technique, right over the top. Some people advocate, let's have enough out here so I can get, there we go. Some people advocate preloading the bougie. I like preloading the bougie. Like I said, that in my kit, I've got a preloaded bougie style tube. But you can make this do without, we can advance to that if you're interested. How deep, for those of you who've been trained on this, how deep do you bury this tube?
I mean, I'd probably get the cuff in the hole visibly And I wouldn't go much further than that.
Not much further than that. So the point here is that you want a cuffed tube in the trachea. You don't want to risk right main stemming. So you bury the cuff just far so it's past the point of incision, right? So you stabilize, bougie comes out, Emma goes on while you are inflating cuff. So, where did I have it? There we go. I like using...
Is Emma the CO2 dealer?
Yeah, the CO2 detector. That is our gold standard for verifying that you've got a tube in place. I like using saline flushes to fill the tube. For those of you who fly, why would I be concerned about you filling the tube with liquid?
Pressure.
Yeah, so it doesn't change with pressure. If I'm flying this person out, my tube's not getting bigger or smaller. So I'll fill cuff. It only takes a couple of mils. I'm maintaining control of this, excuse me. So this was already hooked up. Emma goes on. I verify presence of exhaled CO2. Bag goes on. Somebody bags for me. If I've got the ability, if I've got a stethoscope, for those of you who do endotracheal intubation, where's the first place you listen?
Long sound before belly.
Really? I listen to belly first, personally.
You go belly first?
I go
Okay.
belly first, because if I hear the bloop, that tube's coming out.
Okay.
I don't want to be, am I hearing clear lung sounds? Yeah, back again, back again, back again, back again. Stomach's going, boop, 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 filling up. So I always listen epigastric first, and then I verify bilateral lung sounds on both sides.